Well, good afternoon, everyone. Thank you for joining us today for this special meeting. I think it's, boy, that is a live mic. I think it's holy smokes. It's no great secret that all of us here in local government, in Missoula County, municipal government, throughout the state, face serious challenges relative to budgets as a result of impending or real budget cuts at the state and federal level. And in light of that, and in light of the potential downstream impacts to health, safety, economic vitality here locally in Missoula County, we thought the time was ripe to have a dialogue where we can hear from partner agencies, county departments, in terms of what they see coming down the pike or are experiencing right now relative to budget impacts from decisions made in either Helena or Washington, D.C. And also invite the broader public to join in that dialogue and conversation, because I think it's important from an education standpoint that everyone know exactly how these impacts might trickle down to us locally. So we've invited some key staff and departments and elected officials to present. So we'll run through a number of staff presentations. We'll then engage with our partner organizations and partners in the community to talk about some of the challenges they face. I would ask that folks in the audience hold your questions until after all of the presentations are completed. And we'll then have an opportunity for those of us around the table here to engage in some Q&A. Also hear from folks in the audience today what your thoughts are and any questions that you might have. And again, I thank you all for coming. And as per tradition with all of our public meetings, I will open the meeting by asking, is there any public comment on items not on the agenda today? Okay. Well, seeing none, we'll just roll right to our agenda. I don't know if everyone in the audience was able to pick up a copy, but we'll just begin. And I should say, since I don't think we have any name tags up front here, I am Missoula County Commissioner Dave Strohmeyer. Off to my right, your left, is Commissioner Gene Curtis. And off to my left, your right, Commissioner Cola Rowley. So with no further ado, we'll begin with the Missoula City County Health Department, Ellen Leahy, if you'd like to take it away.
Okay, thank you. Thank you, commissioners and partners, department heads, members of the delegation, the media, the public, and my colleagues that I work with. Well, my PowerPoint's really hot. How's that? Can you hear that? I have to sit on my leg just to be above the table, and then my mic doesn't work. Okay. I'll start off by talking about I think the prevention opportunities that we are losing in our community and across the state by a particular type of cut. And I'm going first, not because the health department and what we're experiencing is by any means the most important entity in the community, but it's to talk about how if we don't prevent the things that are in fact preventable, or at least things we can mitigate early in life, we often don't have another opportunity to help people, to help our society, and to cut costs. And so that's the main reason that this particular cut is going first. So be thinking of all my colleagues that you're going to hear about, because many of them deal with the results of failure to prevent early in life. So I'm focusing primarily on the cuts to Medicaid targeted case management for children with special health needs. You've heard a lot about different types of case management. This is one that Missoula County actually was the pilot for almost 30 years ago. We've been gradually building it up for 30 years. It's not the biggest cut. It's not the biggest cut I've been involved with. It is the most topsy-turvy. in terms of being a smart cut. It is not a smart cut, and for many reasons, it's one of the most heart-wrenching. Going into the session, we had two programs that were at stake. One is a partner program, the Missoula Foster Child Health Program, and we partner with Providence St. Patrick and their primary care clinic. We partner with the Department of Family Services. We get an extra bit of money than our usual allotment from the county for the health department to help. They helped seed this project. And we've evaluated this project, and it's already shown very early returns, very good returns. So it had spread to two other places in the county, in the state, excuse me. So that money was cut in October. We managed to keep our program going, and then we scaled it back to the original number. And what we do there is our public health nurses work in a certain manner with foster parents. Those children get many, many different placements. Infants already have chronic diseases, emotional, behavioral, developmental problems, so much induced by their exposure to trauma, the effects of trauma. The good news we got 2 weeks ago is that the DPHHS portion of that three-way funding that you see in front of you will come back, not all of it. So we are looking at how to restore it. I have to caution that we can't restore all of it because what you see in red, the Medicaid TCM money that is cut, gives us a greater net loss. So we won't be able to completely restore it. Targeted case management, depending on need and depending on staffing, we bring in $145,000 to $190,000 a year. So small compared to what you see, but this is pay a penny or pay a dollar later. That's a very important funding. This is just a pie chart to show you the piece of the pie that's in bright red. Doesn't look very big, but it is about 20% of our usual revenue. And what's really neat about it is that revenue allows us to support all the other programs that sometimes fall short. It allows us to take a referral if no one's eligible for a program. It's just a family in crisis. We can handle them until we get them to our partner agencies and follow up. So we've lost more than that chunk. I'm afraid of hitting the wrong button here. There we go. After the cuts were effective March 1st. We still don't know exactly where we stand after those cuts, but you can see we have a smaller pie. We have 27% less revenue from the state and a huge reduction in that Medicaid targeted case management. So that is it's like a paradigm shift for us, and I think it is for our referral partners, and it's certainly very worrisome for the families that we're currently serving. Just about everyone in the room has seen this. Why does this little cut compared to the millions? You can hear about tens of thousands and millions that we're losing somewhere along our system. Why does this cut matter? Because it's preventive. That's why it matters. So this is the cliff that any of us, particularly as an infant or a child that could be exposed, born with something difficult, been born in poverty, have a health problem, developmental problem that didn't get fixed. This is the cliff any of us can fall off of, and many of our children do. Then that cliff goes down to an ambulance. So if we don't prevent people from falling off the cliff, they end up in very costly and difficult circumstances. What we try to do in our society is we try to build a safety net. Here, when many of us serve in a safety net capacity, we try to build up our primary prevention. That's a fence. And we try to move people away from the cliff. So if you're born in poverty, if you were born in a family that had domestic violence, there are scientifically based things and best practices that can be done to make it so that eventually somewhere in your life you don't fall over that cliff and we're all paying for it. That's what we're losing. We used to be able for almost 30 years now to take any Medicaid child. The parent could have this most minor risk, like maybe birth of twins a few weeks early, and get in there and work with that mom for a few weeks, helper. It could be a child who has a congenital problem that is fixable, like a cleft lip and palate. That's pretty common. But the child has to eat now before the surgery. It can be something that simple. It can be something as difficult as a child born to a parent with a developmental disability. We had a case not too long ago where that mom was failing to show up for her well child checks with baby, and the doctor called us. Very common. Nurse, can you go? Public health nurse, can you go check? Public health nurse got over there, and the baby, from the time between the last wild child check and the one when the nurse went in the home to that Missoula resident's house, had dropped to 1% of the growth chart. The baby was at risk of starving. These are completely preventable and mitigatable situations. It didn't matter if it was a nutritional problem, an environmental exposure problem, a behavioral problem, a developmental problem. And in fact, with children, you don't know what it is until the nurse case manager works with the doctor and the family and you get the assessment. You don't know what it is, but when you figure it out, then you can get a care plan. So we used to be able to do that and be reimbursed at those small amounts. The tax money always makes up the difference, or has so far. As of March 1st, we've taken away this whole part where we work. It was supposed to be reduced by a small amount. It was reduced by 3/4 to 80%. And I still don't know why it was clawed back that far. So I won't go through all this, but basically all those kids I just described and those parents with difficult or early fixable problems, common problems, are not eligible. The child, if they're less than the age of 1 and they were born with a low birth weight, premature, or the mom used alcohol or drugs during pregnancy, not after pregnancy, only during pregnancy, or if they're in foster care and have one of these problems, we can serve them. After that, after age 1, the child has to have one of the conditions on the right-hand side. They're at the bottom of the cliff. They have to already be infected with HIV. They have to already have a brain injury, a neurological diagnosis, congenital heart disease, have required a ventilator, have some level of paralysis or chronic disease. That is not preventive. These things cost money. So we took our cliff that we've built up, and we took the fence out, and this is basically what the policy message is to me. We are expecting a 77% decrease in eligible children. In 2017, we served 533 babies and children, and of course their families, for about 4,000 visits. With a 77% reduction, we think we can serve 176. So this is a scaled reduction of how many preventive services we can't deliver. Monetarily, there's a lot of research that shows that home visiting, and there's different types of home visiting, some have greater yields than others, but we use only evidence-based or best practice scientific approaches. What you see in this chart is for every dollar that was cut in this program, according to the Casey Family Report in this particular citation, which is dated 2014, you've actually later on are going to spend $1.80 up to $5.70. So it is not a savings. It is an exponential addition of costs to society. And I would add that with children, you don't have to wait 20 years to see those costs. Children are very now beings. They need their food now, their shelter now, their brains are developing now. It's happening now. So this isn't just 20 years later. This could be tomorrow. Where are we at? I do not know why, when we were slated to lose 13 to 18% of these funds, how we ended up with a clawback of what appears to be 77%. That is not what the legislature adopted. It's not what the governor proposed. I don't have an answer to that. I have asked that question. We're learning the effect on some of our families right now. We're holding our families as we figure out how best to deal with them. We've already lost a net 3 public health nurses to be available to the community, and we haven't balanced the budget yet. And we're very concerned about the effect on our primary referral partners. Everybody here is a primary referral partner, us to them, them to us. We're very, very concerned. Hospitals, doctors, Department of Family Services, schools, daycare. So I leave you with that, and I appreciate the opportunity to bring this forward. Thank you, Commissioners.
Thank you, Ellen. Our next presentation is from Partnership Health Center.
I'm Jan Thomas. I'm representing.
We need to make sure you have a mic.
Yeah, and I should say, for all the presenters and folks in the audience, when you're speaking, please use the microphone. MCAT is recording today's meeting, so thank you.
Can you hear me now? Yes, I'm Jan Thomas, representing Partnership Health Center. And I want to start by saying that Partnership Health Center is a federally qualified health center. We're a part of Missoula County, but we do receive federal funding to provide services to our patients. And we've sustained one state cut. It was approximately $650,000 per year, but the impact to us has not been that great because we were able, through attrition and through some other openings in our facility, to employ those people who were in that program. And actually, the state is working on another program which will be a replacement for the one that we've lost. So our impact in terms of that program is not that great. Probably the bigger impact to us is going to be any cuts that occur to Western Montana Mental Health and some of the other providers of mental health services in our community. And so we're poised to take as many patients as we possibly can and continue to provide those services. Of course, there's a cost to this because there's the potential that we will be hiring new workers, new, caseworkers to provide these services. But, through our federal funding, we're able to offer a sliding fee scale discounts. And we do work with as many patients as possible to help them afford the services. But then on the other hand, then Medicaid, I believe, has cut the funding for the services down to 50%. That means we can still bill for the services. It's just that the number that we can bill for is reduced. So obviously a big impact there to the community, really. And it's nice that the feds do have funding for mental health services. Going forward, I don't know what the picture is for that, but we do receive funding for behavioral health care. And so the other thing that I would mention is for us in terms of on a local and national scale, PHC has really seen a difference in the number of patients who are on Medicaid and private insurance since the implementation of the ACA and the Medicaid expansion. And so the way that looks for us, and I'll just read this to you because I'm not really that good at quoting my statistics. So in the first quarter of 2015, we had about 4,500 billable Medicaid encounters, but by the fourth quarter of 2017, that number had increased to 7,000. And then private insurance also increased, and in the first quarter of 2015, we saw about 2,000 encounters that were billable to private insurance, and that number has increased to about 28%, and that's leveled off. But obviously from this, you can see that if there were any cuts in terms of Medicaid, we would be greatly impacted, and for private insurance as well. We just don't have specifics at this time because we don't really know what that picture is going to look like in the future. It's something that we're cognizant of and thinking of it as we go forward. So, thank you very much.
Thank you, Jan. Next, we have Chantel Gaynor with Relationship Violence Services.
Thank you. Thanks for having me. My name is Chantel Gaynor with Relationship Violence Services. We serve victims of crime who are going through the criminal justice system and folks who are coming to get orders of protection who may not have any interaction with the criminal justice system. We do focus on sexual and domestic violence, although we do serve victims of all violent crimes. We are not directly experiencing cuts, but our clients are impacted by cuts in other services. And going back to that idea of a safety net, the folks that we serve largely have multiple issues going on, and being a victim of a crime is just one piece of that. But when they can't access services in our community, they're at greater risk of seeing increased violence, having to stay with an abuser, not being able to get services for their kids. And I've got a couple stories that illustrate that, but per usual, we'll start with some statistics. Women with disabilities, so this would be a physical disability, are at a 40% greater risk of domestic violence. And sometimes this violence does not look like the domestic violence that you might think of. It could be somebody who's withholding the use of an aid, so like not letting someone have access to their wheelchair or making them stay in soiled clothes. It's still part of a pattern of power and control, but it can look a little different. In terms of mental health care, domestic violence and sexual violence can both put someone at higher risk. So if they have a mental health disorder or issue, put them at higher risk of violence, but also violence can cause mental health issues such as anxiety, depression, PTSD. And then clients facing homelessness. One of the leading causes of homelessness for women and children in Missoula County, but across the country, is fleeing domestic violence. And so we've got people who are choosing, do I stay in a home that there's occasionally violence, or am I living in my car? And so, we've got folks who are up against all these kinds of choices. In 2017, the CVA program, that's a Crime Victim Advocate program, saw nearly 1,800 clients. Roughly 10% of those reported being homeless or at risk of homelessness, and another 10% reported having a disability or a mental health problem. But what that doesn't say is how many of those things co-occur. And so we definitely have clients who are facing homelessness, who have a mental health problem, who also have a physical disability, and are trying to figure out supports for their kids. So they're looking for resources across our community to help them find safety out of abusive homes. So one of these, the outcomes of the cuts that are happening, one of the cuts in Medicaid is to reduce the rate that providers get for providing services to folks with Medicaid. And as a result, there's a lot of providers who are opting to no longer take Medicaid to serve these folks. We have an in-house referral list to counselors in our community, and on that list we say who takes sliding scale, who will do Medicaid, who will do some pro bono services. And just this week we were reaching out to see if information is still accurate, how folks are going to be proceeding with cuts coming. And 75% of the people that we talked to said that they're going to be eliminating Medicare patients. And so, this leaves people out in the cold. We know they need services, and now they can't find a provider, or the handful of providers who are still taking Medicaid are so backed up that their waiting lists are months. And as Ellen so eloquently said, these are now problems. And think about, if you have just left an abusive situation, your kids are falling apart because it's disrupted their lives, you've moved 3 different places, you don't need services in 9 months, you need services this week. Another issue that's happening is due to fewer providers, CPS is seeing a real backup in folks who will provide evaluations for families. So if CPS is involved with a family, they need an evaluation, and that helps build their treatment plan. When they can't get an evaluation, it backs up the time it takes them to work their treatment plan, which means their kids are staying in foster care or at Watson's longer, and it means that those families have a much harder time working through their treatment plan in the time that they're allotted. And sometimes this could be that they're assigned to get substance abuse treatment or mental health care, and if they can't find a provider, they can't get into service, they can't complete their treatment plan, they can't be reunited with their kids. And all of this builds disruption and trauma in families, and we see it come out over and over again. And finally, one of the things that we're seeing is CPS has begun ordering some of their folks to come get an order of protection from our office, regardless if they really qualify. And it's because it's one of the few legal protections that someone could get today. And so we have folks coming in who don't want an order of protection. They don't feel like they need an order of protection, but they said, well, CPS said I had to do it. And so we're trying to work with them. How can we build a safety plan that helps you get what you need without necessarily using tools that are inappropriate? In terms of the outcome, so one of the things that this looks like for me is like trying to squeeze a water balloon. You know, you squeeze it one end and it bulges out at the other. You squeeze it this end, it bulges out at the other. So we're making cuts here, but we end up with costs here. There's, like I said, a couple stories that I'm going to share, and you can see how that plays out. So one, there was a grandma who had custody of her kiddos, or of her children's kids, who was seeking rapid housing and had come out of a violent relationship. And part of the violence in that relationship had centered around her being forced to use drugs at some point, and then she had continued using drugs over time. Well, in trying to seek housing, she tested positive for meth, which is an automatic call to CPS, which is an automatic placement. So all she wanted was to be able to get into substance abuse treatment, and she was told it was going to be over a year. So again, these are now problems, but we're telling people you have to wait a year or longer to be able to address them. Another one, and this was a woman with disabilities. She had a stroke while she was giving birth, and it left her fairly disabled. And her fiance had started using some of those tactics that I talked about. She finally reached out to law enforcement when he took the infant and didn't come back to the house for a very long time. So when she started looking for services, how she could leave this relationship, how she could get the help that she needed, well, she needed high levels of medical care and she needed high levels of child care. Our local shelter does not provide these level of services, and there wasn't an appropriate placement for her anywhere. So she's put in a position, do I go home to this unsafe home? Do I go stay on a friend's couch who doesn't have capacity to help? Or do I give up my child? And these are choices that people shouldn't have to make. They should be able to have their children have safety, have dignity. Finally, the last story, and this one is a bit older, but it speaks to what happens when we don't have services in our community. In 2010, there was a homicide in Kalispell, and it was centered around a fellow who had high levels of mental health issues as well as high levels of meth abuse. And he had essentially gone on a bender and was going after his ex-partner. And she knew it and had contacted law enforcement. They stepped up. At one point, she was at work. They shut down the entire establishment to keep her safe. Well, it was Christmas time, and his mom, grandma, really wanted to see the baby. That they had an 18-month-old in common. And she felt like, it's Christmas. She should really be able to see this baby. So grandma assured her that everything was going to go fine. And when she took baby over, he was there laying in wait and killed her and her older teenage daughter. If Kalispell had had supervised visitation, if Kalispell had had appropriate services for that family, they could have had a safe exchange. She could have dropped off baby, grandma could have seen baby. But instead, his defense cost over $1 million because it was a death penalty case. So as a state, we paid $1 million for his defense rather than pay the upfront costs of appropriate services for families. So these sorts of cuts get at that. We're going to pay, but what are we paying for? Are we paying for the tragedy or are we paying for the prevention? Thank you.
Thanks, Chantel. Next, we have Missoula County Attorney Kirsten Papst.
Good afternoon. Thank you, members of the commission. We appreciate this opportunity. Thank you to all of our community partners who are here today as well. As you know, my office is divided into two divisions, our civil division and our criminal division. We have 22 attorneys that work in the county attorney's office. 3 of those are dedicated to civil representation in the county. 4 are exclusively dedicated to working with dependent and neglect cases, kids in foster care. And 15 of our attorneys are criminal prosecutors and respond. We are by definition a responsive agency, a reactive agency. So we are sort of the last line of defense for the community and for those who fall on the criminal justice tracks. We react to different groups of people. We react to folks who are mentally ill. We react to folks who are chemically dependent. We also react to folks who are psychopaths and a small group of folks who are good citizens who make very poor choices, impulsive choices. But those last two, the psychopaths and the good people making bad choices, are a very, very small percentage of our business. The largest contributing factors to the criminal justice response are mentally ill people and folks who are chemically dependent, or a variation or a combination of those two things. According to PBS, 73% of women in prison have been diagnosed with a mental illness. 55 to 70% of men in state prisons have been diagnosed with mental illness. Many of those are also have co-occurring diagnosis and are chemically dependent. As you know, there's a continuum of responses when someone's in crisis. So we start with healthcare responses and things that our community can do. Prevention, those efforts that we do. We've got the mental health system in place, the social work system in place. It's a continuum. By the time they get to the criminal justice system, they are at the very far end of the continuum of responses. When the earlier responses that layer each other and work with each other are inadequate, we see people emerge and they fall through all of those safety nets and end up in the criminal justice system, incarcerated. And as you know, that's a very, very expensive way to treat mental illness. When we look at these numbers of mentally ill people that are emerging into our world, it gives us a pretty good snapshot of the failures of the other systems and how the mental health system is functioning locally. When the mental health responses are reduced, or in this case, gutted, the criminal justice system, by virtue of our charge to protect this community, steps in to perform functions that we're not very good at. We're not very good at helping folks who are mentally ill. We're not very good. It's not what we're here for. We are here as the final stop when someone commits crimes that make them a danger to the community. We're not here to make people better. I've brought a couple of my frontline prosecutors to talk to you about their very real experiences in working with the populations and the folks that we are here to serve. I'm going to start and have Jordan Kilby give a few words, and then I'm going to ask Brian Lowney to make a statement.
Thanks. So I'm Jordan Kilby. I'm a deputy county attorney, and for the last year and a half, I've been responsible for the mental health commitments in Missoula County. And people who suffer from serious mental illness come into my world as a last stop. It's when the community systems and supports have failed them and they are at their worst. They have become a danger to themselves, they are suicidal, or a danger to the community, or they cannot meet their basic needs due to their mental illness. And that's when the county gets involved and we file petitions to place these people against their will in commitment or in mental health treatment. It's my opinion, based on my experience, that case management is really the buffer for people between staying in the community and functioning in the community and facing being placed into institutions. So with these cuts, we have seen a rise in our office just in the last 3 months in petitions. And so you all know what case managers do, and certainly Western Montana Mental Health can speak to that, but they do things like make sure that people have housing, make sure that they're making it to their appointments with their medication providers, make sure they're taking their medication, which is essential for people with serious mental illness. They make sure that they're filling out their housing vouchers and seeing their doctors, their therapists, going to group. And so with the cuts in case management, and this isn't, a scientific study with correlation numbers, but I think it's more than just a coincidence that In the last 3 years, in 2015, 16, and 17, between January 1st and March 21st, our office has filed 51, 52, and 56 petitions respectively. In 2018, we have already filed 74. So if that continues, which I imagine it will, it's, I believe, if I did my math correctly, and I probably didn't, but it's about a 30% increase. So historically, one attorney in our office, this was a full caseload for one attorney. But if it continues to go up like this, we will be approaching the county and we will have to ask for more support staff. We'll have to ask for more attorneys. The other thing is that the county pays for the detention costs while people are on detention. They pay for their housing and their treatment. And then we also, mental health crises don't happen between 9 and 5. We have attorneys who are on call 24 hours a day, and they get paid overtime to do that. And so we get called in the middle of the night. We have to come in, we have to find a judge, and that is just very costly. And so, again, we're off the cliff with these mental health commitments. And if we would just fund it up front, I do believe, and I think the numbers bear out, that case management absolutely helps people in the community. And besides the numbers, we don't want to put people in mental health facilities when we don't have to, if they can stay in the community. So that's it.
My name is Brian Lowney. I work for the county attorney's office as a deputy county attorney in the criminal side of things. My caseload generally is sex crimes and domestic violence crimes. I'll just echo what Kirsten and Jordan and Chantel said. We see people come into our system because it's the gap filler. It's the system that is there to respond if no other system is. So these people on Jordan's caseload with mental health issues sometimes show up on the criminal caseload, or people with unchecked drug issues show up in the criminal caseload, or, if these unsafe exchanges are going on, if it's not a homicide, it's an assault, unsafe housing, people going back to situations that they shouldn't go back to that results in assaults or other person crimes, kids in situations they shouldn't be in, results in more sex crimes. As a real example, as to the budget cuts, the things that we've seen, for instance, the Supreme Court court administrator recently, in this last budget session, their budget was cut, and they used to reimburse us for expert witness fees. We would have expert witnesses come in these cases and testify, explain the dynamics of sexual violence or domestic violence, which is a real necessity in jury trials, because I think the community understandably doesn't have a good sense of how these crimes occur, that we need experts to explain the counterintuitive behaviors of victims who are in these situations, especially in sex crimes. And those experts are often people that we call in from out of state. Our local expert community is great about it, but sometimes they're not available or they don't have the breadth of expertise to speak to that. And that's costly. The Supreme Court court administrator used to reimburse us for that. With these budget cuts, they don't do that anymore. So that comes out of our budget. As of about a month ago, we're running about $12,000 over budget, and I expect that will just continue to go up. It's not sustainable for the long term for us to be able to present these cases in the way we need to. And if we are going to be the agency that fills these gaps, we need a way to hold people responsible. And our ability to do that is impaired greatly by these cuts.
Thank you. Next, we have Gary Evans and Jason Kowalski from the Detention Center.
Hi, thank you for the opportunity. I'm Jason Kowalski. I'm the jail commander. I've worked there for 24 years. I've kind of seen some trends. A little background on what our detention facility is today. It's a 396-bed facility. In 2017, we did reach a population of 430 inmates. So we've been overcrowded. We've been overcrowded since 2010. Right now, we've seen a dip in the population, so we're actually under population, but we expect with the nice weather that it'll start to fill up again. There's a lot of stuff going on within the jail. We have a complete mask unit. It's the Missoula Assessment and Sanctions Unit. It is operated or paid for by Department of Corrections. So these are inmates that we hold for Department of Corrections on a contract basis. We've done that since opening our jail almost 20 years ago. This is to help alleviate overcrowding within the state systems, and it's a good program that works well. We also have a county jail for adult offenders, male and female. These are for people to be incarcerated from our community, arrested by any law enforcement agency within our county, including the Highway Patrol, University of Montana, the Missoula Police Department, Fish and Game, Forest Service, and our own county deputies. We also have a juvenile detention facility that's 24 beds. We do hold for some other counties within Montana, and they pay us a daily rate for the inmates that they place within us. We also hold federal inmates. There's really no federal facility in Montana. They contract with jails throughout Montana. It's a pretty regular practice. We guarantee 22 federal beds at all times to those contracts. We also have inmates that are sentenced in Missoula County, and those inmates become Department of Corrections inmates. Basically, the day they're sentenced, and the state picks up the tab for those inmates when they're held within our jail. So we're facing two separate cuts from the state level. One is to that mask unit, that they froze the rate that they want to pay for an inmate, a daily cost for an inmate in the jail, and they froze that at the fiscal year rate of $83.28 a day. So that number would generally go up every single year as our operational costs go up. That number is based on approximately 36% of our overall budget. That's what the state picks up in that daily rate. That amounts to, so in fiscal year 2017, that cut, that freezing of that rate amounts to about $370,000. The second cut represents the rate that the Department of Corrections pays on the inmates that are sentenced in Missoula County and being held in Missoula County. And they reduce that rate to $69 a day. In actuality, it costs $101 per day to keep an inmate into our jail. So it's right around $32.75 less than what it actually costs to hold them in our jail. And that we usually negotiate a rate with Department of Corrections for those inmates that loss really translates to about a $200,000 loss. So both of those cuts together is about $570,000, which is 4% of our overall budget. So it's not, in the whole scheme of things, it's a large amount of money, but we're also dealing with a $14 million budget in our jail. So we are going to provide quality services regardless of those cuts. I mean, we're not cutting any programming. We have to make up that money some other way, and that is our challenge that we're facing. But as our population increases, when we reach that 430 inmates in a 396-bed facility, costs are increasing. That's more clothing, more bedding, more food. That's where our challenges really start to amount as well. We do a really good job trying to reduce costs to the taxpayer for our jail. We are always looking for cheaper products, lower costs by vendors that may have to come in and do some maintenance work. We don't always get to take the lower price because we want a quality product at the same time, but we do have people working in that jail trying to reduce the costs at all times. The jail is very well maintained. It's not falling apart by any means. There's some upkeep that has to happen every single year. That upkeep has been projected for what we know is needed. We are pretty well funded for those needs already. Like one major component of the structure that needs to be repaired is our roof. It's almost 20 years old and we have a rubber roof and it needs to be recoated. We've already discussed that. We've already have funding in place to provide that, and we'll be going after that. When we start talking about these cuts and everything you've already heard today, the safety net that Ellen kind of spoke about and the removal of that, unfortunately, that safety net sometimes translates into the human element of what comes to our jail. Not all of the patients that fall through and go through that safety net with it being removed come to the jail, but it certainly impacts the jail and the service to those individuals. 4 years ago, the county developed a diversion program through support of the sheriff and the commissioners to try to look for avenues to reduce the number of inmates that didn't necessarily need to be in jail. And all the cuts that we're talking about today impact our ability to satisfy that. So through diversion, we've actually reduced the number of people in our jail that didn't necessarily need to be there. They needed to be connected with services, resources, sometimes employment, sometimes a place to stay. The jail's done a really good job in the recent years of those lower risk offenders that come to us and making those connections with them. That's what I'm afraid is going to happen, is those cuts go away and those services go away and those people stay in our jail that don't necessarily need to be there. The 3 top placements for diversion inmates from the jail go to Western Montana Mental Health. They're connected with Winds of Change and 3 Rivers. That's the most popular placements that we can actually get them from the door of the jail to those services, and it's been very successful in them not coming back. So I'll just say the best scenario is to not rely on the jail because of these cuts, that we need to figure out ways to keep all those resources in place so that we don't unnecessarily hold people in our jail. Thank you. Gary, did you have anything? It's Assistant Commander Gary Evans here.
I think that for me, as I look today at your being here today and opening this dialogue, dollars and cents are hard decisions, but the human impact associated with those dollars are very, very difficult to calculate and understand. I think that it's very courageous of you to open this dialogue. I agree with what I've heard so far from those people that do direct services to those people who are in a hard place in their life and they need that help. We have seen an increase. I know the last time I spoke with some of your staff, we were quoting 60-some% of our inmates are on some type of psychotropic medication at all times. At the time I spoke last, it was 71%. There are a lot of hurting people and a lot of hurting families. And we have human tragedy occur in our facility every day. And it takes a toll on everyone. I have become quite good friends with our county attorney's office because they have had to increase their services for us because of those tragedies. Just today alone, we have had tragedies where there are people trying to take their own life, where we send to Warm Springs, and when they're back 20 minutes, they're trying to take their life again. And all of those people have families. I applaud the fact that you're looking at this and taking this so seriously. And Jason and I pledge to do whatever we can to help in any efforts we can to try and help those that are suffering in our community as well as in our facility. Thank you.
Thank you. Next, we have a presentation from Western Montana Mental Health.
County Commissioners, thank you so much for having us here today. My name is Mary Windecker. I'm with Western Montana Mental Health Center, and I want to tell you just a little bit about who we are and what we do. I know most of you know, but I don't know if you know the history. Community-based comprehensive mental health centers were created in the 70s. There are 4 of us throughout the state, and we were created at a time when we were trying to keep people out of institutions and move to a best practice, which is treating them in the community close to their families and close to their support systems. We've spent 40 years creating that system, all the way from targeted case management up to emergency detention if that's required, and everything in between that we were able to provide. We are now, in the last 3 months, basically dismantling that system that has served us for so long. The effect has been pretty substantial to us because every cut that comes down hits us in one way or another because we are comprehensive. So the first round of cuts that were largely the targeted case management that so many of us have talked about, and the 2.99% across the board Medicaid cut was a cut of $4 million to our overall budget, which is $41 million. So that's substantial when you look at the fact that we are not reimbursed on a cost basis. We are reimbursed at a regular Medicaid reimbursement rate, which is pennies on the dollar. Both Partnership Health Center, the federally qualified community health center, and the critical access hospitals, the smaller rural hospitals, are reimbursed for the cost of actually providing that care. For whatever reason, comprehensive mental health centers are not reimbursed in that way, so we have very little margin to weather a storm like this. In addition to the $4 million, there were another set of cuts that have just been postponed. They're trying to redo the addiction and mental disorder divisions brand new adult manual that has cuts against substance use disorders, as well as some additional outpatient and group rates that they're going to be cutting. We haven't calculated that cost yet. We're still waiting to see what the final cuts are to see how that will impact us, but it will be substantial as well. To date, we've had to lay off 60 people. And many of them were targeted case managements, but there were also many people who were therapists, different administrative people that we had helping, rehab caseworkers. We've had a number of people who have been cut. Many of those people had been with us for decades, so it was heartbreaking to dismantle that system. We've closed completely both our children and adult targeted case management programs. The only targeted case managers we still have are with the progressive community treatment programs, the PACT programs that we've moved people into. We can only treat in each of those PACT programs 70 people. Over 5,000 of our clients were impacted by these cuts. That doesn't mean they all lost all their services, but they were reduced in services or moved to a different level of care. What you're talking about with the targeted case management, these are people who can live independently in the community as long as they have help. We've taken that help away from them, so we're now no longer able to do housing applications like they need. We've tried to move them into outpatient day treatment where we do group settings and fill out that, but they're falling through the cracks. We just don't have the people to be able to give the one-on-one kind of care. I mean, think if your entire support system was removed from you in a 2-week period. How do you do all the things you do through the course of the day? And these people have it even tougher. We've had to close both our Dillon office and our Libby office. Those two communities we were able to support because of the money made in the urban centers through targeted case management. Once that went away, we were no longer able to keep those offices open. So we've transferred that care to different participants in the area. Sunburst, for example, took over a lot of our Libby clients. But they're not as comprehensive. So if they need a higher level of care, we're still in the crisis centers that we have to be able to serve them in. There's been cuts in rates to our female adolescent group home in Kalispell, and we are going to have to convert that to an adult group home. It was one of only 4 female adolescent group homes in the state. So now there is no recourse other than to ship those young ladies out of state. So it's a much higher cost, much higher level of acuity, and many of them just will not go. They'll end up on the streets. We've closed our family-based services, and our home support services are looking at closure as well. Those go into the home. They're case managers who support the families as well as therapists. Those cuts are coming down as well, and we'll be losing them in July. We've closed the Ronan office, but we have been able to open the Nest, which is a women's and children's group home that treats pregnant women who are addicted. And that's opened up in St. Ignatius. We have another home here, Carol Graham Home, that's been in existence for a long time, that also treats women. 30% of the babies born in Lake County last year were at risk for having some sort of an addiction issue. So it's becoming a real epidemic, and now's not the time to cut those services. We've had to reduce staff in our Anaconda office, and all of these small towns that we're talking about were hit with job service closures, Office of Public Assistance closures. We've just decimated these poor towns that really have no services any longer except to drive to Missoula or Butte or someplace closer to get these services. And typically, the clients that we serve don't have the money or a car or the ability to get somewhere to be seen. One of the other impacts that we're looking at in the new manual is that they remove some of the language regarding disabilities. So the old criteria was that you could be put into an emergency detention facility, either if you were a danger to yourself, danger to others, or 3, grave disability is exhibited by ideas or behaviors resulting from the DSM-5 diagnosis. Well, somebody crossed that 3rd criteria out. That's how all of our voluntary commitments occurred. So now we're down to just the 10% of mandatory emergency detention. The voluntary ones were people who were decompensating and realized that they were decompensating and said, give me 5 days someplace just to get my act together. And we were able to do that. Now, I don't believe that AMDD intentionally crossed that out. What I think happened is somebody who didn't understand the impact of that language crossed it out. And that's one of the issues we're running into, is when people who don't understand healthcare and mental health care make decisions, it's never good for the community because they don't understand how important it is. So as we've seen these cuts just continue and continue, we're very concerned that we're going to end up in some place like the state of Kansas, who cut and cut and cut, and now it's going to be a generation or 2 before they can recover. We can't get back those case managers that we lost. We're not going to be able to ramp that program up anytime soon, even if people turn it around. But overall, really what we're looking at is we need to get past, as a state, being a state of scarcity and looking at a state of revenue. And how do we do that without raising taxes or coming up with fees or something? Nobody has an appetite for that, but it is getting worse and worse, and I really don't know where the money's going to come from for detention or county attorneys or aging services or anyone else as we continue to cut these things. So I'd love to see us come up with some really great revenue-producing ideas instead of pitting all the social services and departments against each other. You know, don't cut us, cut Sunburst. That's not helpful. We need to really come to a place of plenty as a state and start taking care of our people. I think that's everything I had. Thank you.
Thanks, Mary. Next, we have Susan Kohler with Missoula. Well, I guess I'm going out of order. I guess next we have Child Development Center, sorry.
My name is Carolyn Prusen, and I'm the Executive Director at the Child Development Center. The Child Development Center, much like Western Montana Mental Health Center, our services evolved about 40 to 45 years ago when deinstitutionalization of people with disabilities occurred, and funding for support of those people went into the home and community. So we've been around for 40 to 50 years, supporting kids and their families across 7 Western Montana counties. We hold contracts with the state DPHHS to provide a home visiting program for kids birth up into the age of 18 who have delays, or at risk for having a delay, or at risk for having a disability. Our job is to partner with families to support kids. And what we're trying to do is work ourselves out of a job so that families, parents who are their child's most impactful and important teacher have the skills to be as independent as possible from agencies like ours. We serve approximately 400 kids in Western Montana, about 200 in Missoula County. Our Our biggest program is an early intervention infant toddler program. We serve kids in that program from birth up until the age of 2 years, 11 months. And this program, research shows across the whole nation, that if 67% of the kids that go through this program to optimize their development, 67% do not go into special ed public schools, which is a huge, huge savings, and it's a testament to the effectiveness of this service. We have suffered from, our families have suffered from not only significant cuts across all of our services, but the elimination of some of our services as well. Our Medicaid waiver services have experienced that 2.99% cut. Our Part C infant toddler programs have experienced a 13% cut in reimbursement. However, the state is expecting us to serve 15% more children than we ever have. For kids that are 3 to 18 years of age, we've experienced a 37 or 35% cut in reimbursement. And finally, we've experienced the elimination of our evaluation and diagnosis clinics, which the medical community here relies quite heavily on the Child Development Center to evaluate and diagnose children who have very complex developmental histories. One of the main roles of those clinics were to diagnose children on the who are suspected of being on the autism spectrum. As I'm sure most of you know, autism, the prevalence of autism is on the rise. 1 in 68 children, people under the age of 18 have autism. 1 in 42 boys have autism. Just in Missoula County alone, we serve about 250 children with autism. And we know there are more out there that are not being identified. Unfortunately, Missoula only has approximately 3 medical professionals that are trained to diagnose kids under the age of 5. Their waiting lists are 4 to 6 months long. So when you're looking at a child who's 18 months and you have to wait another 6 months before they can get a diagnosis, they're going without critical treatment. We're limiting their ability to maximize their development. So that we typically did about 60 evaluations every year for to diagnose, rule in or rule out autism. Now that funding has been completely eliminated by the state. This poses a huge issue for our communities because these kids are going to be showing up on the doorstep of the public school system at age 5 with no intervention having occurred prior to that time. So spend $1 now, pay $100 later. That's kind of what it amounts to. So in the last year, we've decreased, our operating budget has decreased from about $1.5 million, which is approximate, 20% of our budget, maybe, yeah. As of July 1st, we're losing an entire program called Children's Waiver Services. It's case management for children who have the most significant developmental disabilities, those who have severe behavioral and or developmental disabilities. That has been eliminated from our contract, and that's about 60 children locally. That is yet to be, that service is going through an RFP process right now, and it is yet to be determined who will be providing that service, but they are estimating that rather than serving children, one staff to 15 families, as we had been able to do, that these children with the most significant disabilities and our most vulnerable kids in our communities will be served with one staff per 70 families, which is basically a non-existent service. As of July 1st, when we lose that program, our staff will be reduced from 250 to 275 people to 50 to 60 individual staff members. We've laid off at least 10 employees. We've had resignations. There's just so many unanswered questions about the future that staff have not felt comfortable hanging in there to find out what their demise will be, if there is one. And just the elimination and the reduction of all these critical services is so disheartening that it's just really, really hard to go out there and do the job knowing that you're not able to give families and kids what they need. So, Greg, do you have anything to add? No? Okay.
Okay, thank you. Now, Missoula Aging Services.
Now? Yeah, the green light's on. I guess that's the indicator, right? I'm Susan Kohler, CEO of Missoula Aging Services. Our job is to promote the independence, dignity, and health of older adults and those that care for them. As I was listening today, common themes in terms of how we're all interrelated and some of the challenges from birth. And if you're lucky, you grow old. And some of those people that were in these systems end up at our doorstep. Last year, we served over 30,000 people, and that was just for Missoula County. Our service area is both Missoula and River Valley County. We see probably, and many of them are adult children coming to us to try and sort out what are the options for their parents as they age and are less able to take care of themselves if their adult children even live in town. Our budget is much smaller compared to some of the organizations here today. We're just a little over $4 million, and our state is only 17% of our funding, which happens to match what the wonderful county does for us, so that's also 17%. We don't get a reimbursement per person that we serve. We get a flat amount and then a generalized description of who we can serve or the type of services. Probably the one you've heard most about is our Meals on Wheels program. It focuses on nutrition, and it's often one of the main reasons why people are able to stay in their own homes. Last year, we served 109,000 meals to over 850 older adults and people with disabilities. Those people, most of them would have ended up in an institution if we weren't there delivering them the meals. When I talked about rippling effect, the cuts in Medicaid to dentures and dental services, nutrition, again, that impacts people's ability to have good nutrition. What we try to do is, let me just address the cuts. The state cuts are about 2.5% of our state funding. So that's only, it's about $18,000 to $19,000. Next year it'll be more. It'll be more to the 20,000. But the other thing we're very worried about in general is, and needs to be at least mentioned, is the federal dollars. The Older Americans Act funding, of which we get our federal funding for, it's not an entitlement program, it's considered discretionary. So that means that with the tax cuts that were done federally and they need to make up that money, they go after programs like ours. And yet, in the state of Montana, we'll be third per capita of older adults. And when you look at a budget like mine for $4,000, serving over 30,000 people in 1 year, any amount of cuts is difficult. We try to raise money close to $850,000 a year in order to keep our Meals on Wheels program whole. And our costs don't stagnate, nor does anybody else in this room. So every year that cost goes up a little bit, and we have to figure out how to find the money. So in our case, the only program that we had that did do what you would consider fee-for-service is our Care Transitions program, where Medicare, we receive the resources to follow people who are 65 and older out of the hospital when they're discharged, and then we're in the home and we help them do medicine reconciliation, make sure they get an appointment with their primary physician, and a lot of what you'll hear about in now and in the future is social determinants, is the language used as to what really affects people's ability to live and be successful health-wise. And those are things like, of course, we've heard it's housing, also meals, transportation, and of course, medical care is an important part of that. After the demonstration project went away, we continued the program. We have to raise our own money to continue it because it was one of the most successful programs nationwide. And so I feel like all of us are in that position where it's not like any of us had too much money to start with. And we're eking by, and then we get a cut. And we're seeing things go back 10 years or more. And that's discouraging if you've been in the human services field for as long as some of us in this room. It's really discouraging to see that you're making a difference and then the rug gets pulled out from under you. I don't know the answers to it because I also hear the other side where people don't want to be taxed anymore. But it's very difficult. I do want to point out many times we're dealing with multiple generations in a generation. So we got people in their 60s, people in their mid-80s, and of course now because of longevity, we're dealing with people over 100. And so it's not a homogeneous group of people that we deal with. And oftentimes it doesn't matter if you have money or not and some of the issues that happen as you age. I'll give you the example of Alzheimer's. It's a pandemic right now. It's probably going to break our healthcare system if we can't figure it out. But the impact of families and caregivers and the cost to take care of that is horrendous. And if it wasn't for family caregivers, it would be much worse. Our role is to help people navigate the system, which is very complex. We get probably on the average 1,000 phone calls a month. And we have one-on-one consultations with people. We had there's the open enrollment program for Medicare Part D every year that we get slammed with, but by sitting with some of these older individuals that can't use a computer or can't hear on the phone, help them sort for their medication plan, we put back into their pockets over $500,000 in Missoula County alone just by helping them sort for a different plan, and they have to do that every single year to figure out whether the insurance plan they have works for them. The cuts, what we're seeing around town, they're calling us. What do I do that I lost my case manager? What am I going to do? The housing, the landlords are calling and saying, these people had case managers, they're gone, and they're not managing all right, and we can't keep them in these apartments if they can't manage their lives. A nursing home costs roughly $80,000 a year, and the Medicaid waiver program is a way that we can keep people in their own homes for a lot less money. And those programs have very slowly grown, but still it's an entitlement program. So people, if all else fails, there's no other systems, you go into a nursing home, you're guaranteed at that price. And that's not always the kind of care environment you'd like to live in. Missoula Aging Services, we're a gateway of all services for older adults. So I'd like to just mention for a minute Adult Protective Services, which is the flip of Child Protective Services. The rate of financial exploitation that's going on today to our older adults that are hidden behind the doors, largely done by family members, is it's scary, nothing less than that. It involves the legal system. It involves the Adult Protective Services, where they've closed offices across the state. And when a problem is starting and a population is actually increasing and we're starting to reduce the number of services that are available, I really worry for our most vulnerable citizens. And on a personal level, my son started with child development services. He's an adult with disabilities now, and I would attest to the value of that early intervention. Finally, he's independent with a housing voucher, living on his own with supports, and he lost his case manager. Again, successful adults sometimes need a little help, and we're kind of taking that away from them. So I just want to remind you that our population is aging, whether we want to admit it or not, and whether you have money or not. It's a complex system, and you need help. Thanks for the opportunity, commissioners, to talk a little bit about this, and I hope somebody has a great idea of what to do about it.
Thanks, Susan. Next, we have Andrew, and I'm sorry if I mispronounced your last name. Is it Lau?
You got it.
Okay, Andrew Lau.
I'm Andrew Lau, and it says I'm an LCSW, which means I'm a licensed clinical social worker, and I'm here with Megan Bailey, another licensed clinical social worker here in the community. County Commissioners, I just want you to be proud of the fact that Missoula County is a county that's home to the social work profession. We have two fine institutions that educate social workers and bring them into our community at the University of Montana and Walla Walla College. Jeanette Rankin, our first female congressperson elected to federal office in our state, was also a dynamic social worker and someone who really represents the social work profession for us. And so one of the things I was listening today, I was thinking about the fact that all of these cuts and things that are affecting our clients are really, really key and important. But another thing to really be aware of in terms of your role as county commissioners is that our profession as social workers is under attack. And, you know, Mary mentioned that there have been 60 firings. I started totaling up as I was hearing different agencies. We're nearly now at about 100 firings in our profession since March 1st, or in this year. So this is like a direct attack on the social work profession. One of the things that was interesting is we got a letter that was circulated from Governor Bullock recently, last week, and he talked about all the different costs to our whole economy that comes when we fire social work professionals. It creates losses throughout the economy, throughout the state, because social workers all provide services, but they're also consumers, and when you stop employing people, you really tank the economy in lots of different ways. So you also mentioned that you're wondering about the impact of these cuts, how they would impact people kind of downstream. And I think one of the things that's really important to think about what the role of social workers are we're the people that show up downstream. Our profession basically has two goals. One is that we identify with people in human need and we connect with them at the most basic level. So we work in outpatient practices in all these agencies to be the people that make the human contact where the healing actually occurs. And then the other wing of our profession is that we're social justice advocates. So we have this dual function. And so it's interesting, I'm here with Megan. We also represent a certain kind of continuum in social work practice, basically the old social worker, which I represent, and Megan, the young social worker. And one of the things I like to say is about 3 weeks ago, I was in one of the functions I have in the state is I teach the courses where I teach all the people that do the supervision work for the social workers who are in the licensure process in our profession. So I was in Bozeman working with about 40 mid-level social workers. And I've been kind of like checked out, kind of in a out to lunch kind of quality about these cuts and the way they've impacted our state. And so when I was with these 40 mid-level clinicians from all over the state in supervisorial roles, I was hit with a sense of shock and trauma. because I realize that this is impacting us in all the ways that we've described, but it's also happening in county after county all over our state. So I somewhat unartfully came back to Missoula, and I was addressing basically what Chantel spoke to so well, is that with this period of cutting happening, what outpatient clinicians, social workers tend to do is they flee from Medicaid. And there's reasons why, because it impacts their personal financial resources and their ability to maintain a stable practice. So what I did, somewhat unartfully and somewhat shame-based, is I got on our professionals wall on Facebook and I said somewhat declaratively in all capital letters, if you don't take Medicaid, you don't deserve to call yourself a social worker, right? What happened was I got 80 or 90 responses right away from people, social workers, who feel the fear, who feel the passion. They want to serve clients, but they're terrified. So quickly what we did is we created an organizing group. We met last Tuesday. We had 75 social workers in my office in Missoula, and we started organizing. And we're organizing around two basic issues. We want to answer your concern, and we want to bring people to Medicaid services rather than encourage this flight away from Medicaid services. And Mary spoke really artfully about the collapse of the continuum of care. So, you know, we have worked in the system and beside the system as social workers, but we've relied on this larger continuum of care. Case managers, crisis management services, prevention services. And with all of that collapsing, what's left is outpatient therapists who need to come together to try to stand in the gap. Take the 3% Medicaid rate cut, that's no big deal, we can absorb that, but deal with all of this pressure that's suddenly coming on outpatient, basically licensed clinical social workers. So if you think about all the things that are required, given that pressure on an outpatient clinician, now suddenly, rather than just being a therapist, they have to learn case management skills because there's no one at Western Montana who's providing that linkage of service. They have to be more readily available for those crisis services because there's not ready places for people to go and to be housed when there's these crisis kind of manifestations. So the pressure is enhanced on the clinical social worker. The other really important thing that most people don't understand in terms of some of the ways the state is sort of managing these budget cuts when it comes to our profession is they cut the number of services and then they require some paperwork assessment that allows an additional amount of service to happen for people with SED or SDMI diagnosis. The state doesn't do any pre-management of that up front. So what they allow social workers to do, and social workers are people downstream connecting with clients where they're in all this pain and suffering, they allow social workers to just continue to see clients and patients. And many social workers who are oftentimes not well educated in reading regs and doing paperwork so well because they're so passionate about being in the water with their clients, they'll go beyond those limits, and then the client will get the service, and then 18 months later there'll be a retroactive audit, and then the social worker's finances will become stripped away in an auditing process. So basically the state is not doing any upfront kind of investment in managing service. They're relying upon the social workers' good-heartedness to provide the service, and then they're tracking them with this retroactive auditing process and pulling cash back into the state budget. So you can see why it's hard to get people motivated to stand in the gap. But our passion is to pull this group of people together, to educate them, to get paperwork practices and protocols going so that we can have a group of people who are fearless in their willingness to continue to stand in this gap. So that's our first goal and focus. And then the other is legislative advocacy. And Megan has really been working with me on trying to figure out what direction to go. So to answer like Susan's question, what do we do? And we really don't know. We hear different things from Democrats and Republicans in the legislature. We hear different things out of the governor's office. Some people say there's things you can do now. Some people say there's nothing we can do until the next legislative session. But the thing that we hear over and over again is that we need to keep telling the human story, and we need keep to use forums like this to activate energy around these issues. And so another part of our mission and intention is to really start getting clear about the direction of the legislature. So Tuesday night, April 10th at 6:30, we've been able to invite Mike Kadis from the governor's budget office and Jess Rhodes, who's his Office of Public Health.
Health Policy Advisor.
And she's going to be coming to meet with this group of social workers. And we invite the public to come so that we can begin to ask them about what kinds of things, what directions we can take to move forward in this crisis. So that's what we're about. And Megan, do you have things to share?
Yeah, if it's all right.
Yeah, go. Thank you, Megan.
Thank you. I'm not on the agenda, but I appreciate being allowed to come. So my name's Megan Bailey. I'm an outpatient mental health provider, and I also do program development with Sunburst Mental Health Centers. And we're also a nonprofit mental health center, very similar to Western Montana. I think our distinction now is that we're the only ones in the state that we haven't had to do any layoffs, and we haven't had to shut our doors. We're structured differently. When the case management cuts initially hit, because of the way we're structured, what typical agencies were doing is kind of this robbing Peter to pay Paul thing, where that was the only reimbursement rate that allowed for a pad that kept our other activities rolling. I don't have a lot of those other activities, so I'm able to sustain. So recently, and you can speak to this, I've been fielding calls from probation and parole, and they're saying, nobody's doing addiction, nobody's doing addiction. What do we do? I have 100 people, 200 people, all court-ordered level 1. I said, that's a great question. If I'm interpreting the rules correctly, that doesn't even exist anymore. I don't know. I don't know what you do with court orders for programs that may not exist anymore. And so one of the big things that we're going to see both locally in Missoula and across the state is until May 1, until we know what the state is going to allow for outpatient addiction, I wouldn't anticipate any of us doing anything as far as meeting addiction needs because we can't figure it out. We can't launch a program. We can't allow for new people to participate in a program that may cease to exist now May 1. So that's a big concern. We can't interpret it. The rates proposed in effect, and I don't have addictions currently, but the rates proposed in effect cut reimbursement rates for addiction to about 1/3 of what they are. So it's pretty devastating. The other thing that's really important to note is that you have to be a center. You have to have that designation to bill Medicaid for addiction services. So all of our really low income folks that are court ordered for addictions, there's very few options. Our private prac people cannot pick that up. So that's kind of scary. So just a quick explanation of that. As far as adult case management is concerned, the state has now relegated. So I still have adult case management. I'm going to keep having it. That being said, I'm capped at 96 units a year, which roughly translates to 2 hours of case management a month per person. That's it. That's all I get. So restructuring things in a way where I can still meet needs is getting exponentially more difficult. I'm still going to do it. We're still going to figure out how to meet needs, but the amount of clever leveraging, we're losing about $68,000 a month. I am 10% the size of Western Montana Mental Health. It's really scary right now. Other issues, I had somebody say, this is great. This must be a windfall for you. You guys are still open. I said, oh my God, this is horrible because I've always relied on all these other incredible networks. And that's why I'm good at my job. I'm good at my job as a clinician because I can wrap people up in services really quick and I can help walk them through that to recovery. Well, now I can't utilize public health the way that I used to. I can't utilize child development center the way that I used to. It's terrifying. My ability, my roadmap to meet needs is getting chipped away at every step of the way. So one of the unique things that I was able to do is I was on the Protect Montana Kids Commission that the governor put in place. So just to really show how incredibly important this program is that you have at public health, it is so important that other states have taken note of it. It is like literally emboldened on federal policy now that if you want to do good work in child protection, do what Missoula, Montana did.
So it's really interesting that given the recommendations of the Protect Montana Kids Commission, we're still seeing cuts in these critical services, so critical and so important, other states are doing it. So that's interesting to me. So from that commission, I ended up becoming more politically involved. I took a lot of time off last session on the floor, and I kind of saw firsthand what I was up against. And I noticed we've got some legislatures in the room, but I literally would go to people and I'd say, this is what I do. This is what my agency does. And the economists are saying there's almost a 3-to-1 return on Medicaid dollars. Every $1 Medicaid spent, we're getting $3 in our community. That is so cool. And look at what I can do. What do you think about protecting X, Y, and Z? And some of the people like, yes, we're going to do it. Other people, the guts for the cuts, and they didn't care, and it didn't matter to them one way or the other. I spent a ton of time basically in all these different testimonies that have happened. We had Kafara's committee try to stop the cuts. There were people literally with infants with O2 saying, if I don't have these people, I'm going to have to move to Wyoming because who's going to help me with my child? And still, members of the legislature would say, I have the guts for the cuts. Over and flipping over again. I saw really responsible tax measures get proposed and killed unequivocally, things that wouldn't even matter to us, like a rental car tax. Are you kidding me? That's going to affect the average Joe. Over and over again. So one of the things that I'm excited about with Andy is really kind of building some momentum with policymakers, because one of the things that was really interesting to me is I was talking to Micah Nelson months and months ago with Montana Women Vote. And she goes, well, yeah, you know what happens when the cuts happen at the state level, the counties pick up the tab. And then our property taxes go up and everybody, you know this, it's a vicious cycle. So what I'm hoping is that with education, with educating our employees and our consumer base, that we can really mobilize good activism and hopefully kind of what Andy's starting to do. With that education component, we can be a force to be reckoned with next legislature and hopefully identify funds that will then hopefully allow us to do the services that we need to do. So thank you for your time.
Thank you, Megan and Andy. And thanks to all of our presenters today. So we've got about 26 minutes left. Jeez, fix that. And I think we'll start with some questions if any of the commissioners have questions, and then we'll move to questions or discussion among the group here and the audience. Anything with this? Okay. Well, at this point, we've got a lot of folks out there. As someone mentioned, I think Megan just a second ago, we do have some state legislators in the audience. If you want to pipe in here, that would be certainly appropriate. I think we have some representatives, staff from our congressional delegation here, and anyone else. Yeah, come on up and. Ann, could you manage the handheld mic for folks who might want to say a word or two?
I guess while she finds someone, I don't have a question, but I have a comment about how that is kind of the belief in the history is that when the state makes cuts, the county picks it up. And as we move into our budgeting season and we have a deficit from last year because we budgeted before the state did and then we lost state money, I think hopefully what we're all hearing is the county, that's completely unsustainable expectation for the county to be able to pick up all these services that are cut, and for the community agencies that Aging Services has some county support, but others have some, but not much, and we certainly cannot pick up the slack in all of what's being lost. And we're here as a partner, and we absolutely want to do everything we can, but I hope we can all join in on legislative fixes and community fixes. We do so, and Kirsten does a fantastic job, but I am tired of having to hire more dependent and neglect attorneys because their parents are using drugs. It's gone up exponentially, and it's really depressing, and that's not the solution to the problem. And the jail isn't the solution to the problem, and these community-based services are the solutions to the problem, and that's what we're cutting from. And so I guess that I don't really have a point, but other than, sorry, but we can't pay for all of this either.
I'd just like to add, and Megan hit on this, but the only thing that local government can do to make up those gaps is to raise your property taxes. And that's the piece that hits people the worst. And I know that our legislators, when they go to door, just like we do when you run for office, that's the piece people talk about. They don't say, oh gosh, I don't want to pay $10 to rent a car, or don't raise my cigarette tax. They don't say that. They say, don't raise my property tax. And so I'm anxious to hear some more.
Yeah, I would second that. Suffice it to say that lethargy in Helena and Washington, D.C. ends up equating to doing what we can to address these problems locally in spite of, not necessarily because of, action in Helena and Washington at the federal level. Senator Malik.
Thank you, Commissioner Strohmeyer. I just wanted to say that I appreciate what you were saying, Megan, and I'd like to know when and where the meeting is with Mike Cadis. But we did have proposals, reasonable proposals for tax increases last time that wouldn't have affected the majority of Montanans. The Heart Association, the Cancer Association coming in for their $1.50 a pack for cigarettes, which would cut the amount of health care costs that we're paying for out of the state. The liquor, the rental cars, the hotels, and the increasing taxes on the wealthy, which we cut 10 years ago in Montana. And there's no reason for that to happen when we have one of the highest taxes on income taxes on low-income people in the United States. And so we've got a legislature dominated by people who have dug in their heels and said we will vote for no tax increases at any time in any way. We got the gas tax done, and as you can see, we're improving our bridges in Montana or in Missoula and doing a good job on roads. But that's it. That's all we could do. And so I feel like we were buffaloed at the end of the session with 261, and it's astounding to me because Montana law says that the governor will make cuts if revenue estimates come in, or revenue comes in below estimates. And instead, the legislature did those 10% cuts before the governor even had a chance to look at what was happening. It was an atrocity. And it really put the governor in an impossible situation. But I really want people to hear that there are reasonable proposals for tax increases, and it is a nightmare when I hear people say, well, what are we going to do about taxes? Look at the proposals and back what we had, and please come forward, because the situation needs to change in terms of who's elected and what people are supporting.
Thank you.
My name is Rachel Lopez, and I'm a counselor in private practice here in Missoula and also in Lake County. I'm dually licensed. I'm a licensed addictions counselor and a licensed clinical social worker. And I feel like with all the really good information that we've heard here today, there's a couple of really important things that I wanted to bring out, which is that on April 1st, one of the things that's going to go into effect is that people are only going to be able to bill for 12 sessions a year for mental health and chemical dependency counseling. And that's comparable to saying to someone, oh, you're a diabetic, and so you're going to go to 12 doctor visits a year and your diabetes is going to be cured. And it's so frightening and devastating. I have 3 people right now that I'm seeing twice a week at the request of their probation officer or, the judge. And so these people are either going to have to seek some alternative form of insurance, or I'm going to have to see them for free, which is what I did quite a bit before Medicaid expansion kicked in. And I can't support my business if I'm seeing half of my caseload for free. And it's very, very terrifying to think of what's been happening. And I feel really sad for all the big agencies like Turning Point and, Sunburst, who are depending on block grant money, which basically the state is saying this money is gone. And so our whole service delivery system is crumbling in the middle of the worst addiction crisis that we've ever experienced. In my 20 years as an addiction counselor in Montana, I've never seen anything like the way it is right now. And these babies that are being born, and, you know, it's just the most short-sighted and terrifying thing that's ever happened in my experience. I mean, even during the 60s, people didn't have the attitude that we don't even care about people who are less fortunate. And, you know, it's true that, you know, we don't espouse those values, but the people who have been elected to be the majority, and as everyone over there said, we don't have to wait until the next legislative session. By the time all these halfway houses and treatment services get shut down, the impact is going to create this wave that's going to be devastating. It's going to be generations before it's fixed. And, you know, I'm facing having to move to another state. You know, I just, you know, the other really terrifying thing about these new regulations is that now everybody has to be pre-approved for everything. And that means that you have to see your first client visit for free, because they've got to sign releases, they've got to give you permission, and you won't be able to bill for that. So these are, you know, kind of things that I know because I do my own billing that other people may not realize quite as vividly. And it is pretty alarming, and I don't really know what we are going to do.
Thank you, Ms. Lopez. And since we have a lot of folks here and a lot of folks who might still want to share a word, if you could limit your comments to about 3 minutes, that would be great. Representative Dudek.
I'll limit mine. I'll be short. Thank you all. Thank you, everyone, for talking, and thank you for letting me go. I have to go to a Girl Scout meeting in a few minutes, so I appreciate that. I just want to say that I understand what's been said, and I think that sometimes it takes more for people to stand up and make government work for them than what's been happening. The government was sued for having an adequately funded public education system. We had to do that in Montana to make it happen. And the government was also sued when the public defense system was not adequate. So both of those lawsuits resulted in a stronger government that protected the people and worked for the people. That may have to be what happens in this case if people feel like their rights are being violated and that the government is not working for them. So I've heard talk of that, and it may be a way that people may feel like they need to go. Otherwise, I think everything else has been said. Thank you.
Thank you.
Hi, Representative Marilyn Ryan, House District 99. I sit on House DPH, or Health and Human Services Appropriations. Everything that you've said, everything that Senator Malik said, and Representative have all been, I've heard them, and so has everyone else in the legislature. Seems to be an attitude over there by the majority party that you can make the cut. You've got the money. You can do it. Well, obviously you can't. And Andrew, I know what you're saying. We keep telling you we can't do anything. Oh, yes, we can. I'm very frustrated. I don't know what we can do between now and the next session, because everywhere that we've looked, we've been blocked. That doesn't help you. It doesn't give you a good response. There's one other element that Senator Malik didn't mention, and that was that the revenue estimates, not only did they refuse to pass new revenue measures, but the revenue estimate was $100 million over the governor's recommendation. And that's where the first cuts came in. I don't have an answer, but I will guarantee you we are working. There are 2 committees that I know of right now. One is part of the Finance Committee looking at new revenue. The second one is more of some individuals together gathering, trying to look at new revenue. There are things happening. It's not going to happen quickly enough. Please keep talking, keep stepping forward, keep writing, and many of us are listening. I have seen some softening in a couple of Republicans who were very hardcore. They're starting to hear the message. So I have to continue to say, please, keep writing, keep calling, keep emailing. I don't have a better answer right now.
Thank you, Marilyn. Anyone else? Don't be shy. Yeah, go ahead.
So I serve on both the Child Development Center's board, the Health Department's board, and Western Montana Mental Health Board. So I've heard this quite a few times, and that's a very hot mic. But I think one of the interesting things is I've learned more recently about like how some other states do things. We have to get past the fact that if it isn't Montana's idea, it's not a good one, because there are good ideas out there. And Western Montana is in the process of hiring, Western Montana Mental Health Center is in the process of hiring a new CEO, and our past CEO went to Yakima, Washington. And so I've had a lot of communications with her because I am the chair of the board this year. And I would love to see us take a delegation of some legislative folks, some social workers, and others, and go learn what they do, because they don't do things on this fee-based. It needs to be based on the person. I mean, if Joe needs a case manager and that's really all he needs and he can handle everything, then that's fine. If somebody needs to figure out how to get childcare, that's another thing. I mean, we need to figure this out so that we're taking care of the people and their needs and doing this prevention versus, prevention being proactive rather than reactive. And so I really would like to work with, maybe we don't take a delegation there. Maybe we take somebody from Washington State to come here and talk to us. But I think it's going to take all of us to be the leaders in the state that says this is how we need to handle this, because DPHHS, I feel sorry for them in some ways. They have just been, because they're such a large agency and they have such important work to do, but nobody's really given them any help. They're just saying, where are you going to make the cuts? What are you going to do? And I think that they're kind of in a reactive mode. When everybody's shooting at you, you kind of go like this. So I think we need to take the leadership. I would also like to recommend that we, this is being recorded today by MCAT, and I would love to send the video to the Montana Association of Counties, to the governor's office. We'll put it on our county website. But I think that you guys are amazing. What we do here is amazing, and we work together, but we need people to just see that we're not just making this stuff up. It's affecting people and families. So thanks for being here, and then thanks for working together, because you do.
Thank you, Jean.
I agree about sharing it and making our voices heard, and I very much appreciate the legislators who came today, but we're preaching to the choir. I think essentially almost everybody who showed up today and who came to listen, they get it, and we need to get our message to the people who don't get it and find ways. And again, being a person who has to make difficult decisions, it's so much more helpful when something's broken if people who know come and say, do it like this, or here's something you can do. It isn't really helpful to come to our decision makers with unsolvable problems, because they don't have the background, the knowledge, whatever, to make up these really good solutions. The really good solutions have to come from the people who understand the problems and know about it. And so hopefully we can take leadership as a community in the state in driving forth solutions that make sense and solutions that work, because no offense to our legislators or to us, we're not complete idiots, but we don't know everything about everything, and the people in this room do. And I think that here we have the collaboration where we can come up with something and say, here's how we can fix this problem, as opposed to just saying, here's a problem.
And I think the point is well taken, that the time to work on that fix is right now, right here, not crossing our fingers, hoping that things go well the next legislative session in January of 2019. Any additional folks who want to comment or pose a question? Yes, Megan.
So, like with what's been said, prior to ever going into any of this, I did GOTV, and I did it for Western Native Voice. And our ability to get our consumers registered to vote and educating our employee base and our consumers on why and how these things are happening will be critical if you want change. We have to start now. We have to start doing that. You can register voters in all of your offices. It's going to be really, really important for us, especially when we're figureheads of our organizations, to start leading that movement. Because if we can get people to the polls that are educated, we will see these things get fixed. Guarantee it. And so that's just kind of my personal challenge for all of these different agency heads. Please go back, figure out how to do GOTV in-house. Thanks.
Anyone else? And I would just extend the effort, or extend the offer to any of our congressional delegation staff who are here or perhaps even not here. We'd love to meet with you. We'd love to share on a personal level some of the experiences that we've heard articulated today, because this is a federal issue, it's a state issue, and ultimately it becomes a local issue when we're trying to serve our constituents. Commissioner Curtis?
Just one more thing. So I really appreciate the legislators that are on some of these interim committees. I appreciate all of you, but some of you are on committees that are in the Health and Human Services field. Unfortunately, right now, DPHHS is at least portraying to the providers, you're going to have to do more with less. And they are looking at managed care. They are not inviting the providers to be involved in that conversation, because all of you know how to provide managed care. We've already had managed care fail big time in Montana. But what they're getting out of that is they're saying, well, we have this company from another state that'll come here and do this, and they can do this without paying for those offices and those people. It takes infrastructure to provide stuff. Aging Services does a ton of stuff with volunteers. But if they don't have the infrastructure to help those volunteers, it doesn't happen. We can't expect the churches to take on feeding people. We can't, you have to have that infrastructure. And somehow we need DPHHS, for one, to ask for help from the experts, and second, to quit thinking that just because somebody from Ohio or some other state can provide this, can bid on this service, can follow up on an RFP and say, well, we can do it for this amount because we don't have any offices. It doesn't work. So if you could communicate that, it would be appreciative.
Well, thanks everyone for joining us today, to our local elected officials, to state legislators, representatives of our congressional delegation, partner agencies, public. I'd hoped to say this earlier when our Public Works Director was here, but I'll say it anyway. Today's conversation was focused largely, if not exclusively, on social services, but I think we can attest that there are other impacts, budget impacts from state and federal cuts that are directly affecting our ability to serve our constituents by way of infrastructure. Secure rural schools being a chief loss of funding source, Department of Revenue and others. So there's lots of challenges. I am very grateful that you all have joined us today to begin this dialogue. This is not the last that we will discuss this in the months to come. Commissioner Rowley, any closing remarks? Okay. Well, thank you all for joining us, and have a great day.